Hello, everyone. I'm excited to introduce Dr. Larry Benz, founder and CEO of Confluent Health. Hi, Larry. How are you?
I'm doing fine. Thank you for having me.
So Confluent Health includes over 20 partnerships with 230 locations around the country. I'm going to interview Larry today on a few different aspects of his company. So Dr. Larry, so in terms of Confluent Health, so you started the company how many years ago?
Well, I sort of have a, an interesting career because first and foremost, I went to the U.S. Army Baylor University program. So I was a military PT. And then I started an outpatient physical therapy practice as I transitioned out of the military. So I've actually been in private practice for over 33 years, 1987. I did transition one of my businesses. I sold one of my businesses to a consolidator at the time. And at the same time, I was embarking on a little different view of the industry. I wanted to have a education company that trained therapists in the latest, greatest evidence-based practices. That's Evidence in Motion. I wanted to have a company that worked with prevention in on-site industrial world. And that company is called Fit for Work, which is on location in 700 plus places around the US. And I wanted to have outpatient PT clinics and occupational therapy clinics because that's kind of our bread and butter. That's our history. And I wanted to partner those with private practice folks like myself and others who were interested in consolidating for the benefits of consolidating, but were also interested in maintaining local ownership in their practice, which, as we know, is a good indicator of success. If you look at all the data, any way you cut the data, the most successful long-term practices always have a local ownership.
Absolutely.
So there's a high degree of correlation there. And so when we open practices, it's in conjunction with joint ownership with local private practice, physical and occupational PTs and OTs.
All right, sounds great. So Larry, when did you realize you wanted to leave the military and open up your first practice?
Oh, that's a great question. So I went in the military right after undergraduate degree. So my goal was to become a physical therapist. And the Army had a very enticing program where you became part of the U.S. military. They paid for your graduate school, paid you as a second lieutenant, and then you got to work in some great sports medicine clinics. So it was a offer too good to pass up. Along the way, I knew that my bent was more entrepreneurial. I was a kid who was small and had paper routes and lemonade stands and all those kinds of things, and tried to operate multiple different businesses. Prior to going in the military and certainly after. At the same time, I knew I wanted to stay close to the military, which I have for a long, long period of time. I stayed in reserves for a number of years, and then have maintained a lot of contacts there, and a lot of our employees are ex-military folks as well. So I pretty much knew during my military career that I wasn't going to make it a 20-year career because I had more of this entrepreneurial bent. And you got to understand that's in the late 80s. There's a lot of supply-demand issues in PT and OT around the country. Mm-hmm. Lots of opportunities, and our ability to be able to expand and live out our vision of having, musculoskeletal care and sports medicine care. There's just too many opportunities to pass up on the entrepreneurial side.
Okay, got it. So what was the year when you opened up your first practice, and what was the name of it?
So we opened up our first practice. Now you got to understand, my wife is also a physical therapist. Oh. So we opened it together when I was still active duty military. And the only thing I could do is once in a while moonlight with permission by the military, particularly in the evenings and on weekends. That company was called Southern Kentucky Physical Therapy, or SKPT. Not really good with names. But then those days we started contracting rural hospitals because they didn't have any staffing. But our true outpatient where our heart and soul was at, both on the industrial and sports medicine front. So we started opening up outpatient clinics in cities in Southern Kentucky by the name of Bardstown and Elizabethtown and Columbia and Clinton County. And those all tended to take the names of that city plus the term physical therapy. But the holding company, if you will, was called Southern Kentucky Physical Therapy. And then later we changed it to Kentucky Orthopaedic Rehab Team, or COURT. which was at the time a private practice. Now it's owned by Select Medical, which is a public company. But its roots, despite what you see on their website, were rooted very much in private practice physical therapy.
Got it. Okay. And did you have any partners besides your wife when you opened up your first practice?
When we opened up our first practice, no, but along the way, we had a very similar model then that we do now, which was to partner with PTs and individual clinics. And that's exactly what we did. And that's how we were able to open up so many successful back then. So, we retooled the model and re-engineered it because you have to evolve and change over time. But the basic fundamentals are the same. And that is our belief that a physical or occupational therapist is best going to worry, stay up at night, and be concerned about their clinic if they have some ownership interest in it.
Got it. Makes sense. And do you remember how much was the initial investment?
Well, I'll tell you, one of my first initial investments was $339.12 a month for a Cadwell EMG machine, because I was also board certified in both clinical electromyography and nerve conduction studies and orthopedic. I was dual board certified. And so that was my first sort of investment in a capital piece of equipment, and it was actually a lease. And that lease had a term and everything else behind it. And I may be the first person ever to, at that time, pay off a lease early. I just didn't like debt, still don't.
Amazing.
And then probably didn't lease another piece of equipment for over 20 years. Now we certainly lease some equipment, some heavy capital equipment, but that was what I would call my first real investment. The other investment I made was in our vehicle. I used to do about 50 to 75,000 miles a year driving. When people would ask me where I was from, I'd say it was from I-65 or the Watterson Freeway, because I spent so much time on it, doing EMGs, opening up clinics, working with our PTs and OTs. Our closest clinic at one time was 2 hours away from where I lived. And I would have to, it was an hour time difference. So I'd leave at 4, get there at 5. If patients didn't show up, I would get home at 8 or 8:30. So, it was a real, now these things look easy and overnight success, but they were built on a long pathway of lots and lots of hard work by lots and lots of people.
Amazing. That's amazing. And since you mentioned EMG and CV, do you guys still have, do you utilize NCV and EMG in your current practices?
So we have over 230 sites, and we contract that out where we need to. We have a number of board certified PTs who are board certified in clinical electromyography. And now in the areas of the country where we do it at, we tend to contract with our colleagues. It's not a core focus of ours anymore.
Got it. Okay. Makes sense. In terms of marketing, so compared to when you started in the late 80s to now, how has the marketing changed in physical therapy?
Well, I think a big thing you have to understand is the internet wasn't around then. And so there was no such thing as digital marketing or social media. Actually, I think the basic fundamentals of marketing are still rooted in relationships. I've always believed that the rehabilitation business is a relationship business, that people want to have a relationship with a person. When you talk about physicians that refer to you, and a lot of our practice now is direct access, but when physicians typically start referring to you, it's because of your location or your insurance that you cover or the service that you provide. Over time, and by the way, that's a very rational decision making, but over time, physicians or anybody else who refers to you can't even remember why they referred to you, because it's irrational. It's based on a relationship. It's based on the complexity of their understanding and affirmations by you and their trust in you and all of these kind of soft things that are kind of emotional or non-rational. That hasn't changed. We still believe that our best marketing and billboards are our own patients. Peter Drucker said the purpose of a business is to create a customer. What we say in our company is the purpose of our business is to create a patient who then creates another patient. And part of doing that is through the relationship that you have with your patient. So we've been very, very diligent in really approaching emotional and social skills of our therapists, these sort of non-cognitive skills. I mean, these hands-on motor skills, high quality connections, and all of these things that really matter, empathy, that really make a big difference in dealing with patients. And we believe that they have, you know, a precisional impact on them to create an additional patient. Over 30 to 5% of our patients are former patients, friends, or family members of former patients. And it's something we track and look at every month because it really is what we believe is the driver of it. So from a marketing standpoint, that is marketing.
Mm-hmm.
Now, you also have to be way more sophisticated. And so, yes, we've embraced the digital marketing phenomenon. We do some social media. It's bigger in certain areas of the country than others for us. And then we certainly are high engagers of technology and communication with our patients. So we certainly follow that. You know, in the early days of marketing, you looked at your patients, your physicians, your community marketing, your employer marketing, and your payer marketing, and those sort of 5 pedestals, if you will. Now those tentacles have really expanded, and so you have to have good competencies and good folks that work in your marketing to help you do all that when you have an organization of our size.
Yeah, definitely. Marketing is very important, and actually leads me to my next question in terms of marketing. How much money or what was the percentage of your gross revenue you guys spend on marketing per clinic?
So it's a great question. We look at that statistic in a couple different ways. We would typically not base it on gross revenue. We would typically base it on net revenue. We look at the number of total patients that we have divided by that cost. And so we look at the cost or the access of a new patient. We think that's a really important statistic. But generally in an organization of our size, you can look at less than 3% as a pretty good rule of thumb. That might be more than most average private practices spend, but that includes a lot of training costs, training all of our therapists in call to care and amazing customer service and social and emotional intelligence and all the cultural aspects of it. In terms of direct marketing spend, it's far less than that. We do a little bit on the radio. We do a little bit on billboards here and there, not much. We do a little bit in newspapers, not much. We do drive a lot of ours through digital marketing, our newsletters, our reach outs to patients and everything else. But that would be a pretty good rule of thumb to start with.
Got it. And what would you say your best referral source? Is it direct access? Is it doctor's referrals, or is it internet?
Yeah, so our best referral source by far is our own patients. That's number one. And anything after that is a very distant second. But second to our own patients, I would say it is the relationship marketing that we have with referral sources and influencers of PT, which aren't always physicians. Mm-hmm. Relationship marketing would be second. Direct access as a percentage of our patients has continued to go way up. I guess our number one referral source, if you aggregated all of our data, would be direct access. But then you have to go underneath the service. Did those patients come from referral from another patient? Were they a former patient, a friend, a colleague, family member of a former patient? So it's a little bit hard to, conflate direct access with marketing in that sense. I also think you have to have some presence in brand building. And that happens through digital ads, through some AdWords, trying lots of different things. I think, depending on what stage that your clinic is in really determines your marketing effort. If I was opening up a brand new clinic in a brand new market, I wouldn't do any of that external advertising cost until I had a reputation and a brand that stood for trust, and that stood for reliability, that stood for accessibility, that stood for customer service, that stood for care and compassion. When I felt good that I had those as the basis of the foundation, then I'd feel good about external marketing. But it has to start with your own product first.
It makes total sense. Larry, how many people does Confluent Health employ today?
About 3,000 when you include a lot of faculty that we contract with and other kinds of things. About 3,000.
Got it. Okay. And in terms of when you acquire a practice, right, on the Confluent Health, do you guys buy offices or you rent space in them, or it's different per clinic or per state, per location?
Yeah, so let me articulate a little different verbiage. We don't buy anything. We partner. We do partnerships with partners. And when we do that, sometimes they come with partners that own parts of their space, but that's very infrequent. We look at the real estate business as a different business than the clinic business. But what I will tell you is we have a number of facilities that are owned by, partners within the company, but in the aggregate, it's a small percentage. So we typically lease.
Got it. Okay, makes total sense. And in terms of billing, you guys do billing in-house, or you outsource? What's your model?
Yeah, so we have multiple CBOs around the country that are redundant with one another, meaning that we tend to use the same billing system over time. We have a few of our newer partnerships that might be on a different system that we migrate when it makes sense to migrate. And then we believe in redundancy so that we don't have all our eggs in one basket of one CBO. We find companies can get into trouble when they do that. We also like to have our CBOs in areas where we get cost favorability. So places like Evansville, Indiana, as opposed to Seattle, Washington, places where there's a little bit more availability to scale at a lesser cost.
Makes sense. And which EMR system do you guys use in Confluent Health? Is this
primarily use WebPT? We were big BMS users. BMS was acquired a decent number of years ago by WebPT, and that is still the basis of our revenue cycle management. But our clinics have been migrating to the documentation platform of WebPT in the last several months.
Makes sense. And what are the 5 most important reports each clinic should run?
Well, that's a great question. The 5 of the most important reports that each clinic should run. The data points that I think are the most important, number 1 is what percentage of your patients came from former patients, friends, family. That's number 1. Number 2, I think a real important one is your comparison to visits and new patients over a period of prior month, same month, prior year, compared to budget, compared to your last 12-month average. So you have to have a frame of reference that incorporates longer term averages. Otherwise, you'll get caught in the highs and lows emotionally. I had a great month, bad month, great month, bad month. Well, you really need to graph that over a period of 3 and 12 months rolling averages, as well as variance reports on those same things, 3 out of 12, 12 out of 12 variance. So January, February, March over January, February, March of the prior year times 100 to get to a statistic. So I think all your reports have to run on that. So the first one was friends and family. The second one was new patients and visits. The third would be a referral report to see on average how those referral sources are continuing to refer to you. Okay. Now, the other thing I'd point out is everything you've asked, these are all lag indicators, okay, not leading indicators. These are reports you're running sort of after the fact. We actually prefer in our practice to have lead indicators that are an activity that will lead us to a result downstream. So that's just sort of our overall philosophy. So an additional report I think you need to have, obviously, is everything around your billing and collection rate, DSOs, accounts receivable days. How do they compare? What is your average turnaround time between the time you bill a patient and the time you expect, and how much do you receive? And then I think the last of those 5, not last in aggregate, but we're a big data company. We look at a lot of data. It would be your net revenue per visit to see if that is increasing, decreasing, and staying the same. And is that dependent on your payer mix, your percentage of Medicare, workers' comp, private pay, HMO, auto, all of those things together to get an understanding of why and how that net revenue per visit is changing over time. So that's 5.
Great info, great data. Thank you, Larry. And what would you say the biggest expense in each clinic monthly?
Well, we're a service business, so all of our folks wear shoes, they go home and they sleep at night. And in a service business, 67% of your cost is people. On a net revenue basis, it's about 50% of your net revenue. So there's no question that people are your highest expense. And so how do you lower that as a percentage of net revenue? That can only be done through scale, through productivity, through consistency and training, and through having a service culture and expectations, not only around how many visits a therapist should be expected to see, but what entails that visit? What is the patient loyalty scores from that? What is the net promoter score? We don't use net promoter, but we use something very similar. What are the physical and functional outcomes you expect from that? So outlining several expectations for that huge expense is really, really important. And in our company, we look at the physical and occupational therapy business as a human capital talent management business. We don't look at it as a unit economic business. It's got unit economics that's inherent in the business, but we look at our overall philosophy of how we manage it as human capital.
Yeah, make total sense. Make total sense. And in terms of net profit percentage, what would you say is a good net profit percentage for physical therapy practice?
It's really, really dependent on what area of the country you're in because the reimbursement is so much different.
Sure.
And then it really depends on the focus of your practice when you look at in terms of Medicare or pediatrics or orthopedics or geriatrics and all of those kinds of things. So it'd be really, really hard to extrapolate. You know, I think if you look at the public companies and you see that they have anywhere from, you know, an 8 to call it 11% EBITDA margin, you know, I think if you can, if you're a decent private practice, you can certainly exceed that. But that would be an average across all parts of the United States. So it's a little bit misleading as well. So I still think in today's PT and OT world, you should be getting double-digit margins.
No, average reimbursement rate on the East Coast, United States is about $70, give or take. What is the average reimbursement rate in Kentucky, for instance?
Yeah, in Kentucky, in this market, you're probably looking at around mid 80s, you know, mid to low 80s. You know, the states that are the most over-regulated have the lowest reimbursement rates. California, New York, you know, those kinds of things. So you have to be mindful of that.
Sure, makes sense.
Florida, in part because of the Medicare percentage, would be another one, but it's highly regulated as well.
Makes total sense. Larry, I know you hold orthopedic clinical specialist certification. Do you require all your therapists to have some sort of certifications? And you mentioned you invest a lot of resources into education and marketing. You mentioned that, you know, having therapists have, you know, continuing education. Is that part of it? What are your requirements in Confluent?
Yeah, so that really goes along with our human capital orientation. And so we have Evidence in Motion, which is our education company. And we have an implicit social contract with every employee, with every therapist that comes into our organization. And that contract states two things. One is if they were ever to leave us, and we hope they never do, but if they ever were, they're going to leave better than when they came in. And second, they will be placed on a pathway of clinical excellence. And that pathway's ultimate hurdle is board certification. So board certification in PT is only about 5 to 6% of all PTs. You know, you can quadruple that or more for our company. Our goal is to have 100%. Along the way, people either complete a certification program or a residency, and they obtain board certification. Oftentimes, something can get in the way of that. They don't pass the exam, for example, or there are other hurdles to get to the exam, a certain amount of time, certain number of years. But make no bones about it, we want every therapist to have a certification in a board certification for sure.
Okay, thank you. Larry, you also have MAPP certification. Can you tell our listeners what that certification is?
Yeah, so I have a master's in applied positive psychology from the University of Pennsylvania. You know, back not too many years ago, I elected to go once a month up to an Ivy League school where I was accepted to study along with about 30 or 40 other folks under the stalwarts like Marty Seligman and Angela Duckworth, James Pawlowski, and many, many others to learn about these non-clinical indicators of clinical success. So I was very interested in how all of these can be transported into clinical physical therapy, into healthcare, because we tend to be unhinged or disjointed from the psychological and neurosciences in our world. And my goal was to try to link those two together. It ultimately culminated with a capstone that I did And I have a forthcoming book that'll be published later this summer entitled Called to Care, Rehumanizing Healthcare. That is, in essence, my experience in the research that we did coming out of that MAPP program.
You actually answered one of my questions. I wanted to ask you when the book is coming out, because I actually heard you working on a book. Okay, great. I'm also interested, you do have an MBA degree, and I'm very interested to know, once you decide that you want to get an MBA, at what point of your career?
Yeah, it's a great question. So I got my MBA when, by any conventional standards, we would have been considered a successful company, and I would have been considered a successful or an achieving CEO. So I waited to go back for a variety of reasons. I didn't have the time, effort, resources, whatever. And when I went back, I was glad that I waited, because had I had a more conventional training, I would have taken on less risk. I'd have been more cautious. And the entrepreneurial spirit and zest, I think, would have been squelched. Having gone after I had already had a pretty successful business really allowed me to integrate my experience plus the didactic pedagogy of an MBA curriculum. And so I thought it was extremely helpful. I learned an awful lot, had some great classmates and teammates who separated us in teams, and some relationships I still have to this day. So it was a wonderful experience.
So would you recommend clinic owners obtaining an MBA degree? And at what point of their career would you recommend doing that?
Yeah, so it's interesting. So the MBA degree is agnostic, healthcare, engineering, accounting, finance. If you're looking for that, understand that you will learn about manufacturing and other areas. There are some healthcare MBAs for sure, but and those are good experiences. The best way to learn sometimes is to learn from others. What we did at Evidence in Motion is we implemented an executive management program so that folks can work on their company while they're also working at school. And so our program is a 12-month program. We've been doing it for about 10 years. We've had hundreds of graduates, all private practitioners for the most part, where they can integrate sort of advanced learnings in an MBA style curriculum into an executive management program. We also offered a post-professional physical therapy and occupational therapy degree, what used to be called a transitional degree along with that. So they took some clinical courses at the same time to meet the fulfillment of the standards for the DPT and for the OTD.
Okay, makes sense. And one of my questions is, I guess, what is the long-term goal of Confluent Health?
Yeah, so the long-term goal of Confluent Health is to keep doing exactly what we're doing, evolve with the times, but continue to be a resource to be able to partner with private practices who want scale, sophistication, and systems, but who will still want to be able to act like a private practitioner in their local market. And so we're going to continue to do that. Evidence in Motion continues to add physical therapy programs, and we're adding occupational therapy programs. And then Fit for Work is continuing its strategy of really preventing injuries for on-site employers, particularly in high-risk injuries like material handling and manufacturing and such.
Larry, thank you so much for your time today. These are all the questions I had in mind. And it was a great pleasure speaking to you. Great honor having you on today's podcast. And I'll speak to you.
Thank you. Appreciate it, and good luck to you.